A very good morning to the august people on and off the dais. I'm here to speak on iatrogenic trauma, and specifically IOL drop. Excuse me. There are no financial disclosures to make. Now, IOL drop is actually complete dislocation of the IOL into the vitreous chamber, which may be either intraoperative or postoperative, and this may again be early or late. Intraoperatively, that attempt to implant.
May I call Dr. Inder Mohan Dustagi? Please come the front seat. So you are one of the moderators. Thank you. Yes, Dr. Soni.
So this usually occurs intraoperatively on attempting to implant an IOL in the presence of PC rent or zonular deficiency. So this can be either intraoperatively or pre-existing. So as in this video, you saw that a sulcus lens was being implanted, dialed, and the visco removed. And as soon as the wound is getting hydrated or moxifloxacin is being put, the lens is already tilting, and hey presto, the lens lands at the bottom of the vitreous cavity. So post-operatively also it can occur either early, within 3 months, when it occurs due to, when the IOL haptic is rotated away from the area of capsular support and left as such, or it can occur late, after 3 months due to trauma, progressive zonulopathies, vitreoretinal surgery, or a progressive contraction of the anterior capsule. So there are many predisposing factors, including pseudoexfoliation syndrome, retinitis pigmentosa, diabetes mellitus, aging, axial myopia, etc. And the diagnosis and investigations entail taking a good history and examining all previous records of the patients, including those of treatment, taking the BCVA and intraocular pressure, assessing the cornea for future lens implantation, assessing the residual capsule, doing a good indirect ophthalmoscopy with a scleral depression, going in with investigations such as B-scan, ASOCT or UBM, taking a specular count, having a macular OCT and a biometry if we are planning to implant a lens to have a good prognostication, and to distinguish between in-the-back dislocation versus IOL dislocation alone. So the prevention would be to avoid implanting a conventional PC IOL if the status of capsular rim is uncertain, and to inflate the inferior iridocapsular sulcus with viscoelastic to accommodate the leading haptic, and leave the superior haptic in the sulcus and check the stability of the IOL before leaving, and avoid dialing the IOL too much in case of extended rhexis. The complications include vitreous hemorrhage, retinal detachment, CME, and cyclodialysis. We have for the management a choice for observing some asymptomatic patient or patient without inflammation, if the IOL is non-mobile, not having any retinal complications, or if the patient is just satisfied with his aphakic correction, or there's surgical intervention just cannot be done in a non-consenting patient. But the proper management would be a surgical approach, when either you can do a PPV with or without a PFCL, that is perfluorocarbon, lifting the IOL to the anterior chamber and placing an IOL over if possible. The same IOL can be repositioned in the sulcus, or even scleral fixated in case of a 3-piece IOL, or a sulcus fixation in a 1-piece hydrophilic IOL. Or the other options of putting in the IOL would be iris fixation, scleral fixation, or an AC IOL. It all depends upon the status of the cornea, iris sclera, and comfort of the surgeon. But assisted levitation is really not recommended. So this is a video where you have a rigid IOL, UV blocking IOL, where the triamcinolone is put in, a vitrectomy is performed, and a PVD is induced, and just around the IOL is mobilized as best as possible, and then finally the haptic is caught with that of with an foreign body forceps, and the IOL is removed via the anterior route, being a rigid IOL. This is the second video is that of a foldable IOL in the mid-vitreous. As the vitreous is mobilized, the IOL falls back onto the macula. So to protect the macula, a PFCL is injected. The IOL floats upwards and of course peripherally, because the upper surface is convex, and finally is taken out by the same anterior route, by the handshake technique. And then finally folded up within the anterior chamber and taken out through a relatively smaller incision. So, and the ports are closed. So, the prognosis regarding iatrogenic trauma and after taking out the IOL would be that 85% have been known to achieve a visual acuity of 20/40 or better. Pre-existing disease leads to unfavorable outcomes, and close follow-up and management can help to avoid the above, and cautious pre, intra and post-operative assessment are required. Thank you.
Madam, I really compliment you for a wonderful presentation. It's an eye-opener for most of the audience present here in this August gathering. My point is that would you like to highlight about scleral fixated lenses in such situations?
Sir,
You are not a mention of that. Scleral fixated implants, where you're explanting the IOL
and yes, that was
posterior
what
iris
that
claw
is.
implant.
Of course, if when you're implanting, then also it can drop. When there have been drops of scleral fixated eyes during the implantation also. So, and if
These are the different modalities, of course.
I mean, after the removing that lens, you can place another scleral fixated lens. Nowadays,
that is true. That is true.
Right there.
So rehabilitation, yeah.
Yes, sir.
It could be primary, it could be secondary
Yes,
also.
sir. One of the slides it was there.
So,
Iris fixated can be anterofixated or retrofixated, preferably retrofixated to take care of the endothelial count. Yes, we can do that.
Thanks, Sony. And the next speaker, Dr. Pradeep Mohanta.
Discuss on this topic. This topic. You are a discussion for this topic for 4 minutes. Please come here.
मैम से एक दो क्वेश्चन तो पूछा सर.
किसको? मैडम
हाँ, वैसे कैसे जान दे रहा हूँ.
पूछिए.
Sorry, I was late and I just saw the last 2 minutes of the video. Ma'am, if we plan posterior iris claw lens, then we can make a scleral tunnel and we need not fold the IOL in the anterior chamber. Folding the IOL in the anterior chamber is more manipulations. There can be touch of endothelium by the lens, by the forceps that we use to fold the lens. So better we make a scleral tunnel, remove the IOL through a wide tunnel, maybe 6 mm, and then place a PMMA retro iris fixated lens. That will be a better option. Any other questions so that we can discuss?
We can use a different type of scleral fixated lenses.
That is
The innovative PM design patented lens of scleral duct lens, which is self-sustainable and as well as that does not require glue or suture. We have published that in IJO and we have done more than 300 cases now. So that can be done. That can be done in post-trauma as well as post-iatrogenic cases, and even in presence of this and following endophthalmitis, we have done at least 10 cases, and they all are doing great.
So I think more than 30 years experience we have in this field, and looking at the published literature also, I think these surgeons should be versatile. They should be able to do multiple things, and the things are evolving. Last time in our innovation center, we had somebody who took out the lenses and they actually redesigned the lens on the table and then could implant the same. So they redesigned it into the type of lens that you told. So so the field is very versatile, and the type of trauma, the iris, cornea, astigmatism, so many factors are there. So I think people who are dealing with this, it should be sort of a specialized person who does the surgery. When the IOL drops, it's not an emergency. It's not an emergency to go ahead and fish it and try to fix it somewhere. Even I have fished out 3 IOLs from the same eye. One has dropped, second has dropped, still that surgeon is putting one more, third one. Now when the third one is there, how do I remove those 2? Now I have to remove all 3. Now when I am removing all 3, how do I charge the patient? So IOL explant, I charge something. Then I don't want to charge the same thing to removing 1 IOL to removing 3 IOLs. Then I put foreign body removal charge. So it becomes very messy. Only message I want to give is this is highly specialized area. There is very good outcome if the surgeon knows what they are doing, and that practice should not be left to somebody who has just done 1 or 2 cases. They should learn different techniques. And sometimes it is glued IOL, sometimes it is SF IOL. Yesterday only somebody showed a case where the IOL was dropping and they removed and they put a single piece IOL in the sulcus. Now we know that single piece IOL doesn't have to be put in sulcus. They will get glaucoma. That patient got 0.8 cupping and 40 pressure for 3 months before she came to us. And like it's sad to say that already it has been taught don't put single piece IOL in the sulcus, but somebody is putting just because they want to put it. So I think if IOL drops for whatever reason, just stop, give the steroids, give the pediatrics, send to somebody who knows different techniques, and then they will put a good IOL. The literature shows there is no one method better than the other. All methods have led to good outcomes if they are done properly.
So I think relevance of this presentation in relation to community ophthalmology is that we must have a meticulous pre-operative counseling of each and every patient. That although we are going to do our best for you, God bless me and you both. Because any complication can take place at any stage of surgery. And what Madam has highlighted, that at times you have to explant the IOL, go for secondary IOL. And if the patient is fussy, you are in trouble. So I think meticulous pre-operative counseling is an important part of every surgery.
Always keep it with guarded prognosis and never make tall claims. That is very important in these cases.
May I ask one question to the House?
As this conference is going on in Calcutta, just I recall and remember one incident of this IOL drop. What happened about 25 years back that make a big hue and cry in Calcutta, in one of the advanced center in medical college in Calcutta. The HOD has operated the case. The first IOL was dropped, second IOL was dropped, and still he put an AC IOL. So there were three IOL in the eye, and patient has got not beautiful vision, anything. Then it gone to the Consumers Protection Court. So for long 5-6 years, it has gone into the public, it has gone into Consumers Protection Forum, as well as up to the Director of Medical Education. And finally it was solved that a surgeon cannot put more than one IOL on the table inside the...
But you cannot go law. You cannot put a law like that, you don't put the second IOL.
No, in the presence of another IOL within the eye.
This was just like buy one, get two free.
Okay, my question is, suppose you have done, the IOL has dropped and you want to refer the case to a VR surgeon, and the VR surgeon knows both scleral fixation of a multipiece IOL like sensor multipiece and posterior iris claw lens. Which one you will recommend to your, to the surgeon you are referring to?
Sir, I think we should leave it to the retina surgeon. However, if at all, that person has got any retinal issues or likely to have any retinal issues, better try to put in a scleral fixated IOL. That is for the vitreoretinal surgeon, not the...
By the surgeon.
We should not be recommending that you put and do this or
And
you
nothing
do
should
that.
be taken
I
in a
think
hurry.
it should be left on the retina.
Yeah, nothing should be taken in a hurry to take decision.
So
Because maybe
the
later
question
on
is,
dilatation will be required, and with an iris fixated, maybe it won't die that way.
Each case is different from the other case.
okay, is it that the long-term result of scleral fixation IOL is better than posterior iris claw lens?
Not only that,
If it
sir.
is sutured, then
Definitely.
it's a problem. So now people are not suturing. We are doing glued, or we are doing the method that he told, which is sutureless. So the Prolene sutures break after some years. That has been a problem in about 15% cases. That's the published data. So that is something which people have to redo.
So glued IOL where the haptic is placed in the...
That will not drop. No? There's no suture.
We have done a comparative study and we found no significant difference in long-term rolling sutures gets disintegrated and
Yes.
those IOL drops.
Yes.
But the cortex suture availability is still the problem.
Yeah. Okay, I think we can.
Comment I want to make in this regard, one comment is, see, these multiple IOLs are put just to save the face of the surgeon.
It doesn't.
Yeah, normally it is done because he has to face the patient and patient party. So he goes on putting. But now, it's better if you have good rexis, you can put the lens in the sulcus. And nowadays, good vitreoretinal surgeons can remove, even if there is if you have done good vitrectomy, anti-vitrectomy, and put the lens in the sulcus, there is no problem. They can take out the lens from the vitreous very easily. There is absolutely no problem. I mean, they can do it.
One more point in relation to your, query, that accidentally if there has been a associated RD with a dropped IOL, and if the VR surgeon has taken care of RD and if he has put in silicone oil for the internal tamponade, then I think scleral fixation IOL is a better choice compared to a posterior iris claw IOL.
So what I think is the VR surgeon has already spent a lot of time doing the other parts with vitrectomy. And this glued IOL will take another 15-20 minutes. And the iris claw will take 2-3 minutes.
That is not the point, sir. Point is not that of how much time the surgery takes. We are more, keen about the prognosis of the case.
Yes, but the
We don't
surgeon,
look at
to
the
save
watch, we look
time,
at the patient's
will go for
condition.
posterior iris claw
Yes.
rather than scleral fixated
But it has
IOL.
been seen,
Can be
Dr.
situations
Pradeep,
like this.
Time is not the factor.
Time is not a factor. It should not be a factor,
You
yes.
spend 2 hours, why not another 15 minutes? That is not the issue. Question is, which is the best?
There is a second sitting while you do the SOR as well as SFIO.
Yes. SFIO. This
You
is
can
how we
take time and
How many
seconds.
days can we wait if we don't put in the same table?
So we can wait for even for 3 months. If let the eye be quiet.
Correct. Once inflammation subsides, then you can go.
I have made a patient wait for 3 months. Cornea is crystal clear. Then I have done scleral fixated IOL.
Not only that, sir, if the patient is apprehensive, anxious, we can even plan for surgery, this second surgery under GA. Never make it a point of issue that I'll do it under topical or I'll do it under peribulbar. If the condition demands so, one must always think on lines of giving GA to the patient.
And
Okay,
sir,
we
one
move
more
on to the
point
next
that
talk-
I did
next
not
talk.
make.
So maybe conclude before
For
the next
posi-
talk.
For positive types, sir, I didn't make one point, and this is very important for colleagues to, battle for the colleagues. Not that there's something stray remarks are being passed by the second surgeon. That should not happen. And the other one is that the patient should be very adequately counseled by the first surgeon, and the second surgeon should corroborate that yes, whatever best could have been done has been done for you.
But one thing I would say, they should not pass any comment against the other surgeon.
Yes,
That's very important. Yes, that is very important. Most
That is very important, yeah.
So may we can conclude that the scleral fixated lens means the haptic is fixated in the sclera is much better than any other scleral fixation lens.
Right. Sure.
Thank you.
Okay, thank you very much for the good discussion on this